Welcome to our webinar, Integrating Artificial Intelligence in Your Access Center. We're going to give folks about 30 seconds to log on. We really appreciate your attending, spending the hour with us to talk about this important topic. So again, we'll give folks about 30 seconds to log on here. All right, by my count, that's about 30 seconds. Just welcome everyone to the Patient Access Collaborative. As you know, we are a learning community of academic medical centers, children's hospitals, and the nation's finest cancer centers. Collectively, we represent 1 out of every 4 patient encounters that walks through an ambulatory or outpatient visit in the United States. So we are excited to be able to share this incredible webinar. We have been honored to have Luma as one of our industry partners, actually now for almost 6 years. And we've really appreciated their partnership and contributions to our education. And indeed, speaking of partnerships, they're actually partnering with one of our most engaged health system members. That indeed is the University of Arkansas for Medical Sciences and their fearless and unbelievable expert leader, Michelle Winfield Hanrahan. So we're going to go ahead and turn over the platform to Aditya Bansad from Luma and Michelle from UAMS. Aditya and Michelle, the floor is yours.
Awesome. Well, with that introduction, I hope that we live up to the hype and expectation that Michelle or that Elizabeth put on here. So hopefully this is a wonderful use of your hour, and thank you so much for spending that time here with us today. We're going to spend a good amount of time talking today about integrating artificial intelligence into your access center. And we'll start with a quick set of introductions. Aditya, one of the founders and CTO here at Luma Health, longtime PAC partner, and excited to have the opportunity to in front of many of you. I'll hand it over to my much more talented partner over here, Michelle, who's would love to get an introduction from you as well.
Thanks, Aditya. Hi, everyone. My name is Michelle Winfield Hanrahan. I'm the Chief Clinical Access Officer here at UAMS Health. And we've been PAC partners since I joined UAMS in February 2021, and super excited to have this partnership with Luma.
Awesome. So kind of giving you all a bit of a roadmap for what we're going to cover today. I'm going to start us a little bit with just kind of a vantage point of access center challenges that we see from access centers. Michelle's going to go into a deep dive around the challenges that they faced, how they overcame it, and how they use AI to grow some of the capabilities that they have at UAMS. And then we'll kind of close out with kind of a little bit of what's next, like where do we grow the partnership, where do we grow AI in the access center. So that's a little bit of the roadmap of what we'll be going through this afternoon or morning or earlier, depending on where you are. So we'll dig in first with some challenges for access centers. And, you're all, many of you operate, run, manage access centers, and the problems that are in front of you are not novel to you, and they are really in the way in many cases of your ability to deliver care into your communities, into their patients. So whether it's this patient Ruth who's coming in a very perfect idealized scenario here where she's an active MyChart user, she can schedule her appointments from MyChart, she's getting fast pass offers, there's no hiccups or reschedulings getting into the office. That's the best case scenario. That's the ideal case. That's where we want every patient to kind of operate. And that's the path we wanted to be in. However, we know most engagements with health systems aren't ever so clean on such a straight line. The line gets very dashed all the time. And I think honestly, Michelle, many times it's not even a line. It's probably a squiggly line. It's maybe an MC Escher diagram, right? As people fall into infinite loops there. So we'll see things like, when trying to get an RX refill or trying to get a specialty visit, they will need to maybe start with a phone call. We'll need to maybe get a fax in from a referral like to get documents from a specialist. The staff will need to reach out, whether it's for insurance authorization or MedRec or whatever it might be. And then, schedules change both for not just the patient, but for the provider. So no matter what is kind of going on in, that ideal path, the reality of healthcare as you live and breathe this every day is we're not on the straight line. It's a dashed line, that MC Escher vantage point, that squiggly line that is often very challenging and, often leads to these challenges here around staff. And, we see this time and time again, all the health system leaders that I talk to around, are we providing great jobs for our employees and allowing them to provide great care and access to our patients? So whether it's attrition rate that comes from patients who are trying to get access, from attrition from staff members who are working inside the access center, to burnout of those team members, or just staff shortages overall, these kind of common core problems exist in every health system. And Michelle, I know you and I have spoken at length about these challenges, where a lot of people who've come up through the health system into health leadership have often come up through these paths. So it's kind of incumbent on us to grow our health systems to continue to provide a really powerful, a good opportunity for employment here.
I would agree 100%, Aditya. I think, healthcare access centers are usually the entry level for employees to join the organization. So it's always important to get them in and have the attrition move throughout your own health system versus leaving the organization because they were burnt out, or they felt like they didn't have the tools to do their job, or they were overstaffed or understaffed on a regular basis.
Completely agree. So, when you have these problems, you might look for alternatives, right? So let's just do a quick little poll in the chat here, try to make this a little interactive. Unfortunately, I can't see your faces, but I like to see your words. So these are the sorts of problems that folks, often experience, which is high call volumes and long hold times, contact center burnout, manual follow-ups result, with after-hour reschedules, lengthy turnaround times. Drop into the chat pod, leave a number 1, 2, 3, 4, 5, or 6, things that you guys experience on a daily basis, weekly basis, monthly basis. Would love to kind of get a little bit of audience participation, so we can kind of really focus in. I got a number 2 in there. So Brandon, thank you for starting that. We got a 1 and 3 from Nikki. Let's see who else. We got a strong 1 from Jeanette. 1 through 3, I assume is what that dash meant. 1, 3, 6, 1. A lot of some 6s, 4 through 6. Seeing a good representation here, but a really strong focus, or maybe a lot of representation in that number 1 bucket here. Yeah, I'd love to hear all this. Hello to someone from UT Southwestern, fellow Dallasite. Awesome. Wow, tons of folks really in that first row, really trying to find solutions for a lot of these problems you have here. And I think, high call volumes, long hold times, especially near some geographies where you have the opportunity, where being able to service a patient in a competitive ecosystem where you might have other health systems that can get the opportunity to serve that patient as opposed to you, really being able to provide great service to that patient is so important. And patients continue to, they want top-notch service. They want not just healthcare service, they want customer service as well. They're consumers who shop around for experiences, they shop around for care. So I find this input that you guys, Kristen, I love yours. At various points in the year, all of the above. Yeah, say less, as the kids say. So
I was going to actually say, sorry, Aditya. I was going to say each one of these 1 through 6 could be impactful even every day. In different times of the day, right? We all know our call volume on Mondays and Tuesdays and Wednesdays is super high, and then dives off on Tuesday, Thursdays and Fridays. But then, no one's working any of the referrals because everyone's managing the call volume. And then you've got Thursday and Friday to manage your referrals. And then that's where your long leg time comes from your referrals. So it is literally a completely cyclical environment that this all occurs in.
Yes. Yeah. So, Michelle, you and the UAMS team, you started working on trying to solve some of these problems. One of those boxes in there, a little bit to lead the audience, in fairness, was one of the problems that you guys were facing. So I'm going to turn the mic over to you. I'll be your, your keyboard jockey over here, and take us through a little bit of what, a little bit of UAMS, and also the what you aim to solve here using AI.
Sure, absolutely. So we're an Epic first health system. We do have a centralized contact center. All of our service lines or services are in the centralized call center. At this time, I think bar transplant, we kept transplant out for a variety of reasons that anyone that deals with transplant would understand. We're the only academic medical center and the only level 1 trauma center in the state. So therefore, we get tons of specialty referrals. We have lag time challenges and wait times for appointments, just like everyone else does. We're also the state's largest public employer. And then our clinical affiliates are an economic engine of about 3.92 billion. We handle about 1.8 million calls per year within the call center. So we're fairly busy on a day-to-day basis. So our biggest challenge is high call volumes, overstretched staff and after hours calls. And when I looked at, what could we fix? What could we tackle? What could we work on that would have an impact that would be positive, that wouldn't cost the institution a lot of money? Because I think we're all in challenging times financially. Overstretched staff, fewer staff, that is usually resource. And if you're not financially stable, it's kind of hard to get that. High call volume, right? We want the high call volume, but we don't want the high call volume because people can't get their phone call answered and they keep calling back in. But the spot that made the most sense after much deliberation with my access team, and I have fantastic senior directors, and we went all the way down to the agent level and said, what can we try to do to make your lives better? What is something every single day that you do that is just incredibly frustrating? And it led to, we, after hours, had a voicemail system for anybody that wanted to cancel or cancel an appointment. We never offered them the ability to reschedule. They just called the call center number. They left their voicemail with their name, date of birth, and the appointment they were scheduling, and hung up. Well, what that led to is every single day, my agents, a select few of them, would come in and they'd have to listen to 3 and 4 hours of voicemails to figure out who canceled. And as you can imagine, as an access center and as an academic medical center, you've got people that are calling at 10 o'clock at night, canceling their 8 a.m. appointment, and we're not getting the voicemail till 8:15 or 8:30. So we now have a no-show. We can't backfill the slot. So this was something that we felt would have a very large impact, would not have a huge, it would have a huge impact on the work, but it wouldn't have a huge impact clinically to providers. So we decided, I think, Aditya, if you want to go to the next slide, we implemented Luma's Navigator solution. And it's an AI solution. His name is Alfred. He answers all our after hours appointment calls and manages all of the appointment cancellations, and then also gives us the ability to reschedule those appointments at point of service. And it has taken all the manual work out of that process. It has given agents back the time to do the true to task work, scheduling appointments, and we're able to backfill, our templates where we have the cancels, and we're also still being able to reschedule. So it had a huge impact. And this was my point, right? When anybody talks about implementing AI, and you're all in an academic medical center and you all know what it's like, with physicians and clinical care, they start to get really nervous about, oh, it's going to impact what we're doing. And, oh, what if it doesn't say the right thing? So this was fairly straightforward. We figured I wouldn't have to go, lobby the entire institution to get approval for this. This lived just in my center, so it was very easy to manage. But we found 95% of our inbound calls to the after hour lines are now automated. 88% of callers are verified as current patients. So Luma did build in a workflow so that we do verify, obviously, the patient name, date of birth, all the identifiers that we would normally use. 88% of the time, that works correctly. I think that other 20%-ish or less than 20%-ish is probably patients that I'd like to think don't know what they're doing. So they kind of say things that trip up the system, and then we know that the patient's not verified, and that just escalates over to a voicemail. There's about 800 plus fewer access center hours spent processing these cancellations annually, which has been a big help. Greater than 10,000 calls are handled annually without any of my staff doing anything. And then 4% of our total call center inbound calls are handled by AI versus our staff. And we are hoping to grow that number with a bunch of additional initiatives.
And I think always a challenge in a lot of these sorts of projects is what does it take to make it happen, right?
Yep. It is. And, we're an Epic first shop, and I think I consulted in patient access for a really long time. And a lot of the things that we would hear in regards to consultancy was, our Epic teams are stretched thin. There's so many priorities. It takes a really long time to get this stuff implemented. And I will tell you, just from the beginning to the end, it was from the time of inception till the time of go live, we were 3 weeks in, and it was just a breath of fresh air to do something quickly and to get an immediate feedback of positivity on the project.
Awesome. So we're going to show a little bit of example of this working. And so the audio is a little bit, I think I'm getting an echo somewhere. Michelle, maybe you can hit mute for a second. Thanks. Oh, cool. Okay. So we're going to show, we shot a little video so you guys can get an example of what Navigator can do, how it works. And I'm seeing some wonderful questions come into the chat pod. We'll grab those a little bit and a little later on. So keep them coming. But we're going to take a little quick look at, what a patient, how a patient experiences this.
Agent from Hayes Valley Health. How can I help you today?
Olá, gostaria de fazer a reposição de meus medicamentos?
Você pode me informar seu nome e data de nascimento?
Claro, Thiago Garcia, 2 de junho de 1985.
Obrigada, Tiago. Posso te ajudar em algo mais?
Eu não tenho mais medicamentos e preciso de mais.
Posso te ajudar com isso? Você tem o nome do medicamento e a dosagem?
Não me lembro.
Tudo bem. Você pode enviar uma foto do frasco do medicamento? Você pode clicar no link no texto que te enviei para enviar a imagem.
Ok, só um minuto, deixa eu procurar.
Acabei de receber a foto. Reabastecerei seu medicamento e o enviarei para sua farmácia registrada na 10 Front Street.
Perfeito, muito obrigado. Tchau.
So we wanted to get you an opportunity to see what Navigator can look like, in a fully developed deployment. When we partnered originally with UAMS and Michelle, we were not at that level of sophistication, obviously. There's a lot of work that's happened since then to get a lot more capability built out and a lot more capability there. So let's take a moment to dive into how it works. And again, if you have more questions about how the deployment is worked at UAMS and kind of what they're doing, I'm seeing some great questions come in. Just encourage everyone to drop those questions in. And then Elizabeth will probably help us moderate answering some of those when it comes time for that. So let's take a quick deep dive in how does all this work. And the way that we've built Navigator and the way that we've deployed it at UAMS is really to sit on top of that epic first mentality that Michelle said at the very beginning of when she was going over a case study, which is look to Epic to kind of solve the core workflow problems and build on top of that. So we've built what we call an agentic workflow. That's an AI concierge. So first and foremost, what we want to have is being able to converse simply in native languages with patients. English and Spanish are supported out of the box, and a couple other languages are coming as well. Second part is around being able to do that without manual work for the staff. So, if you think about this generation of AI-based voice solutions, really being able to just do the solution by itself without tying it into Epic kind of takes away from the whole purpose anyway, right? We're not going to try to create double work. We're not just trying to move it from a voice call to handling an in-basket message. What we want to do really, and what we've done is really kind of close the loop on being able to reschedule that appointment, cancel that appointment, work the templates that might already exist inside of Cadence. And then of course, the goal really is to generate more efficiency for the Access Center. Let them focus on the work that's not just sitting, in Michelle's case, is sitting and transcribing 3 hours of work, 3 hours of voicemails every day. So Navigator of the Box has what we call skills, and skills have a variety of different things they can do. So appointment management, whether it's scheduling an appointment, rescheduling and canceling, rebooking, changing appointment dates and times, that's in the world of appointment management. Number 2 is kind of FAQs and appointment questions, like when is my son's appointment? One of the beauties of Navigator is it's context aware, right? It says, oh, you're asking about your son? I have not verified that information yet. Let me go find that out, get that information from you, and then I will actually enable me, Navigator, Alfred in UAMS's case, to answer the question about the son. Refill prescriptions, and then ask for directions. it's I think you all understand how much of your calls that you get are just like, is the parking free, or where's the parking supposed to be? Those sorts of questions easily decantable to an AI agent so that you're able to focus on better, higher quality calls. So to do that, we want to be able to support patients and their family members in one call. And that's very similar to how your agents would handle it anyway, right? How how Access Center agents would handle this anyway. Hi, I have a question about myself and my 2 kids ahead of school for they need to get their physicals done. Great. We'll take care of that in one call. Obviously, we run 24/7, 365, which, that's kind of why computers are good for those sorts of things. And then multilingual, I saw there's a question there, which LLMs are used for language support. We'll get to that in a little bit, but we've only picked the languages that we have high confidence where the LLMs can perform high quality translations for us. And of course, multi-channel access. Now, this is one of the really cool things that's coming very soon in the roadmap, which is the ability to start a conversation over voice, transfer it to SMS, and then when the next call comes in, pick up the context of what had happened over SMS in the next subsequent phone call. So really powerful ability to kind of have that continuous experience for patients. So doesn't feel just necessarily so transactional with the patient. So let's take a look at what does it take to integrate AI into your call center, into your Access Center, excuse me. So Michelle, why don't you take us through a little bit about your evaluation process for UM's Access Center, and why did you guys start thinking about an AI concierge?
Yeah, so the AI functionality always intrigued me. I always knew that, there was tons of manual work that everybody was doing on a regular basis. And I think it all came to a head when we were trying, when everybody hit fiscal challenges within the last 2 to 3 years. How do we put agents on, how do we get rid of the work that something else could be done, that could be doing that work, so that we could be scheduling appointments and we could be making sure that the follow-up appointments were made for patients. So this is what we landed on, like I had mentioned earlier with the team. And as I suggested before, I didn't want to start something that was going to have this huge impact to everybody in the institution, that we were going to have 12 committees and 14 members all try to determine what this would look like. So, when you think about this across a health system, there's a variety of ways that it can be used. I just wanted to stick within the Access Center to build my business case and then move forward, with all the other things that we can work on. So currently we're working on the prescription refill piece. We're working on referrals. How many times a day do you guys get a call into your Access Center about, have you received my referral? Has the doctor looked at it? Has my appointment been scheduled? So those are like next in our line of things that we want to do, but we wanted to make a use case that knew we would have some quick wins on, and then be able to present that organizationally for future work.
Absolutely. And I think one of the original thesi, however you say that, was really that referral piece. And it's one of the areas where we want to continue developing with UAMS and our other partners, is just the amount of questions and calls that an Access Center gets that are just basically to solve the information disparity between what's on the screen for the Access Center agent versus, the patient. And so that was one of the original use cases that Michelle put in front of us, said, like, can you help us solve this information, just to let the patient know that we're still working on it, or it's done, or we still need some documentation, whatever the answer might be, just to help kind of lower the information disparity between the patient and the health center. Now, oops, sorry, I want to head 2 more. So one of the things that I think, Michelle, you and the folks looked at was really kind of boxing in a little bit on the use cases, because, you deal with probably 100 different dispositions in a day. An agent has to be trained for a lot of different things. There's a bunch of voice solutions that are available, but kind of why did you consider using Luma? Why did you consider kind of building on top of our existing partnership for this opportunity?
From my perspective, when I started this job, is when when I was introduced to Luma, we were looking for a new texting vendor, right? And there's nothing really exciting about texting. We do it all day long. It wasn't really anything of excitement, but we needed a new vendor. And I sat through a zillion vendor presentations, and again, about texting, it's all the same. But what I really liked about Luma was the customer service aspect of it. I love the ability to have reports, to be able to get information that we need anytime. We struggle as I'm sure everybody else does, there's the My Chart messages, and then there's the revenue cycle messages that go out. And sometimes we get some weird messages and everybody automatically goes, oh, send this to Michelle. This came from Luma. And, immediately I reach out to our customer support team and they're like, no, it didn't come from us. And, we do all the due diligence to find it out. So I don't have to wait 3 days to get an answer when we have to investigate something. So and just their integration ability within Epic. We're Epic first, right? And that's important to us, but sometimes Epic isn't exactly where we need it to be, or they're in the process of building things and we need to solve a problem or a solution immediately. And I just had great hope and confidence in Luma to be able to help us do that.
Yeah, and I think a big part of that is really around that like integration, right? And being able to take, there's a couple of questions I've seen in the chat, which, it's like there's business rules that exist inside of Epic around proxies, around surgery shouldn't just be able to be canceled out like, from just an arbitrary phone call or whatever those might be, or infusions. And there's a lot of the power the integration drives that you can build once an Epic or an Oracle and allow, the tools that build on top your other front doors that are built on top to take advantage of those same that are just take advantage of those same capabilities and take advantage of the same build you've already done. So let's take a moment to think a little bit about what's next. So you gave us a little bit of a preview. There's work we're doing on RX refills. So that's super, super interesting. We'd love to hear a little more about that. And then we're also doing a little bit of stuff more on AI and fax.
Yes. So I can you all answer the question yes to this. Every single time we schedule an appointment for anyone in our specialty areas or anywhere, everybody needs records. We need records for care management. We need records for appointment scheduling. I mean, my world is like consumed with records. And I just said to anybody that would listen to me at Luma, could you just please find a way to help us solve this records gathering business? Because it is usually put on a nurse because they think it's something that needs to be clinical because they need to understand, or they want to give it to a telephone agent who isn't clinical, that isn't going to understand it. And then that fails miserably because they don't understand what they're gathering. And it's just this giant runaround. So we're working through the Luma's Fax Transform to work on parsing out and routing fax paperwork referrals and more via Epic to what we need. And I'm so excited about it. I can't even tell you.
And yeah, it's a really cool opportunity that we have in front of us, which is, this part here in this diagram. I'm not sure if the mouse shows over Zoom, but, those faxes still are a major part of the story. And we often talk, especially when we're like forward-thinking, innovative IT folk who think about like the digital front door of care delivery, right, and care access. But really, there's many, many front doors that are available inside of a health center, right? There's the phone, there's the fax, there's My Chart, there's whatever, Care Everywhere. There's so many different front doors that tie into the same ecosystem, and be able to tie all those together is just kind of continues to be a part of how healthcare is going to be delivered in America. So with Voice and Navigator, really done, I think, a great job in service of UAMS to partner with them to deliver to their patients a way to get self-service on the Voice front door. Now, the fax part is one of those next things we're working on, which is our AI capability to take incoming faxes, transcribe them, create orders, create referrals directly in Epic or Oracle Cerner, and then being able to kind of reduce the amount of human labor that's required in order to move records effectively, to move records between health system A or ambulatory clinic, independent ambulatory clinic A, and health system B. And being able to provide that, I think, provides a really good leg up in reducing the amount of the human capital required to kind of just get the patient started on their journey to care. Cool. So let's go ahead.
I was just going to say it's so true. And how many of us have this scenario where providers aren't going to schedule the patient until they have the records? And I know all of us as access leaders have worked very, very hard to eliminate that culture or change that culture. And we have, and probably 60 to 70% of our subspecialties, but there are some areas specifically in cancer, which I'm very close to. I'm the senior nursing director over the Cancer Institute. So, a lot of our providers need staging and all of those things. And it really is no value to schedule the patient before we have this. So we're really trying to find a way to streamline all of it so that, in the cases where it's relevant, we have the information that's needed, and then we're able to secure that information after the fact when we decide, we see the patient and determine what else we need.
Yeah. And I think you and I have had an opportunity to talk a little bit about this exact topic here that's on the visual right now at Vibe, which is what are the opportunities, like what should you be thinking about? I think a lot of the audience, especially kind of reading from the questions, are either somewhere in their AI journey in their access centers or starting their AI journey. Really, I think you kicked us off here at Luma, kind of joint partnership with this almost a year and change ago now. And so you've had a chance to think about this around the consideration. So you want to walk us through a little bit about kind of your mental model on how one should think about implementing AI.
I think every day we all get faced with a problem, right? Every day someone comes in your door and says, I have this problem, I have this need. And immediately it's like, the buzzword is, can AI fix it? What can we use? Can we use technology? Can we this? Can we that? And I think a lot of times people don't really understand the problem they're trying to solve or the impact that solving that problem will have with the functionality that you use to solve it. I know that's a weird way to phrase it, but sometimes you solve a problem but create 10 other problems by solving the problem. So we really needed to work on to define the problem that we were really trying to solve and what was the outcome. And for me, it was get calls off agents and be able to, backfill template slots and have patients have a point of service where they can call at 2:00 in the morning, 1:00 in the morning, 2:00 in the afternoon, and get the same level of service. Again, like I said, everybody wants, when we were at Vibe, that's all anybody talked about was AI. I felt really bad for the Luma squad because it was just 700 questions about AI and everybody's doing AI, right? Every company, everyone out there has some version of it. And I think you really have to know what you're trying to solve to determine what type of AI you need to use. One of the big things for me is having the right people at the table to help evaluate what it is you're looking at, what you're trying to solve, to determine what other problems could occur by solving it. And then again, low risk use case that doesn't require tons of change management. I just implemented this. We just implemented it. We turned it on and nobody knew about it. Patients were happy with it. We got some great feedback on patient experience, Press Ganey scores that they were able to call at 2:00 in the morning and cancel an appointment. And they were happy with it. So that was this. From this slide, this is exactly what I did to achieve the outcome that I wanted, and it was very positive.
One of my favorite stories is when we went live at UAMS. We were reviewing patient transcripts, right? The calls that patients were making, and at least one person and probably a handful more were like, "Am I talking to an AI? Whatever, I got to make this change." Like they just moved on. Like they're like, "Great, got it. I have a job that needs to be done, and I'm not going to care that it's an AI or not." Which was honestly one of the considerations that I think we collectively had: is our patients going to be like, "This is weird. Why am I doing this?" But one of the things I think, Michelle, that you were mentioning around choose something that's low risk, easy to implement, be able to show value up front. I think that's one of the really important parts that we've really started to focus here on Luma is how do we make sure that our tooling is very easy to deploy inside of a health center, right? And so what's really critical for us here is being able to make it very self-serviceable so that teams like Michelle's group are able to self-service, self-manage, add skills, remove skills, create new branches, whatever it might be. So over the last year, as we've built for the UAMS use case, we've kind of generalized a lot of this to make it even simpler to go build a lot of capabilities and deploy a lot of the capabilities with Navigator in an easy drag and drop workflow builder. So we kind of co-designed this with UAMS, kind of with the thought of how do you make it easy for an Epic and Oracle Cerner shops to make it very simple to get live. And so to that end, one of the things I'm most excited to share about with this audience today is we've put together a really special offer for our friends here in PAC, which is an exclusive offer specifically for PAC members, which is we're putting our money where our mouth is. We believe in this technology, we believe in this capability. So we want to give you, if you're the opportunity to use Navigator for free for 4 months. And so we'll provide white glove implementation service. We have Epic Analyst available who can deploy into your health system if you're short on resources, and full data and analytics so that you can see how it's actually working for your health system. So we're really excited about the opportunity to give you this capability. And so you can see, kind of get the benefit that Michelle and the UAMS team received by deploying it with a very low risk kind of capability that's very self-serviceable with the white glove support that we also have. There's limited change management, full design guides that are available, an AI handbook, so that if you have an AI committee inside your health system, that it's available as like an AI toolkit that you can use. So it talks about what LLMs we use and the data retention models and the security modeling and all that sort of good stuff. So there's all sorts of great stuff, and we're making this available exclusively to the PAC community. And honestly, just try it if you want to. I wouldn't say call Michelle's health system, because they're probably doing some more important things in the middle of the workday. But we have a number out here that we're more than happy for you guys just to take down. We can drop this in the chat pod too. Give it a call and try asking a couple of questions and see what you can do to. If you want to try to break it, please try. But we feel really confident in kind of what we've built, and we've had the great pleasure of partnering with UAMS to see the success that they've had, and feel really confident in our ability to deliver some great value to your patients. All right.
I think from my perspective, just to anybody on the call, I mean, it is absolutely worth anything that you can get off your agents, any calls that you can get decanted off, whatever that is. And sometimes I will come to Aditya and say, I have like the smallest baby use case for something, and it may sound really dumb, but I think this is going to be this big impact that it's going to have. So I guess my message is, there's nothing too small, I guess, is my point. Anything that you think will be helpful to your teams is something that I would absolutely entertain trying to utilize this functionality with.
Awesome.
Michelle,
Well, I'll
we
go
have
ahead and
a pile
jump
of
right.
questions.
Yeah, I'll go ahead and jump right in. And I've just had to chuckle when Aditya was like, call us. And I'm thinking Michelle's team is back in the access center going, oh, please, we got enough calls to handle. But love the idea of starting off by calling Navigator to test it out instead of UAMS's access
Yeah,
center.
exactly.
I'm like, I'm going to get a lot of texts right now. Awesome.
I know
Well,
Amber's going to be texting me on the side.
Exactly. Well, that was a really awesome presentation. And so what I would love to do is turn it over into our Q&A period, and just make sure I remind our audience that to feel free to chat at us. We'll be, looking through the chat right now for those questions, but keep it coming, as we're really lucky. We got about 18 to 20 minutes. And so our first question is, what patient verification criteria do you use for the self-service options?
Yeah, so the basics are very similar to, I think, what, if I called into a health center, what I would have to present as a patient. So there's a number that shows up from the caller ID, the first name, last name, and then the date of birth. That's what we ask the patient to verify. And when we were able to do a positive match on that, we performed a lookup into Epic, Cerner, and I'll just answer a question that I saw a little later, which is, do we support Cerner? The answer is yes. Epic and Cerner, to use the lookup mechanism that's in there. So both of those are supported, Epic and Cerner, and we just use the number that came in the caller ID, first name, last name that the patient presents, the date of birth they present, and that once we get a positive match from the EMR, that's when we continue with the authorization.
Awesome. Thank you so much. Is this solution built within Epic, or is there a main website homepage?
So I like to joke, anything inside of Luma, I'd love you to use Luma, but my best case is you don't. And we just basically show up inside your Epic, show up inside your Cerner as if we're an agent, updating appointments, confirming appointments, scheduling sort of stuff. In Epic and in Cerner, both, I'll just make sure to tie it out on both sides. We're showing up inside the audit records, inside the EMRs, like all that stuff looks there. And so that's kind of like, we want to be as native feeling as if we're just another staff member. And we have a panel you can dock inside of Epic and inside of Cerner that lets you look at and load Luma directly inside of there, so you don't have to have another application to log into.
Thank you so much. And I think this is the question of the hour or the day or the week, which is return on investment. And Michelle, I know you presented that page that had, the calls saved, et cetera. One of our members is asking, do the savings associated by having the AI technology handle 4% of your calls, have you proven, does that offset the cost of the technology? And if you could just expand on sort of that ROI question a little bit for us.
Sure. So we never looked at it, and I never presented it. So I guess I should back up. You know, when you start to talk about we're going to use AI and we're going to use this to take away some of the work that a human being is doing, the automatic response from the CFO is, great, can we get rid of people? Which isn't necessarily always the best way to go. And then secondly, then everybody that is a human in the access center is worried that their jobs are at risk. So we never looked at it from an ROI perspective of like a hard, like if we utilize this, is this going to help pay? You know, are we paying for this through the use of the AI? And I approach it from the perspective of it gives me the ability to have more people on the phone to schedule more appointments. And that was the ROI route I went. Because if I'm spending 3 hours a day listening to phone calls, that's 3 hours that someone's not scheduling appointments. So we went on the ROI perspective of the lost revenue that we had from not being able to backfill the template and not being able to offer a reschedule at point of service. And then what that would mean when we got those agents off the phones doing more true to test work. So I don't know if that really answers your question. And I know, you know, a lot of people, I always call things like the warm and fuzzy ROI. And then there's like the hard and fast dollar ROI. And I went the warm and fuzzy route with dollars attached, but not saying that this is going to save us X amount of dollars, because that wasn't the intent.
Yeah, Michelle, I think that's a really, I mean, may even be the best point of the webinar today is, you know, I think that everybody's talking about AI as a replacement for staff, but really I love that slide about going back to what problem are you trying to solve, that, you know, there were four, starting with the problem, because it isn't just about replacing people. And in fact,
Right.
if we think of it like that, we don't even have enough people to begin with. And so if we get rid of more, we're really going to be in trouble. We're just looking at it from the lens of access here, but it's a really, really great point. So I appreciate very much the response to that question. So our next question is, for the 5% of calls that aren't able to be solved via the AI solution after hours, what happens to those calls?
I believe that they roll to a voicemail, but I mean, we have 5 voicemails a day versus, you know, 3 hours worth.
Fantastic. And what language model is used for the translations?
Yeah, so the solution actually uses 3 different models. So just to give an extra bit of detail here. So there's a speech to text model. So that's when people are speaking, converting it to written text. There's the generative AI model, which is used to kind of answer with the data that we're feeding in. And then there's the text to speech model. And so we have DeepGram, OpenAI, and 11 Labs. Those are the 3 that kind of sit that we orchestrate. And then those are all set up in what we call a zero retention model, which means that there's no training happening on that data. The data's destroyed after it's sent to the models. And so it's in what we call an ISO 42001 compliant mechanism, so that we're kind of running through it all with the zero retention framework. But it's the coordination of those 3 LLMs, those 3 models that make the entire solution kind of come together.
Well, there's a lot of tech language, but
Yes.
I appreciate it.
I get to be the nerd,
much.
though. I get to be the nerd.
Thank you. As you heard from the top, we have a lot of children's hospitals that are part of the Patient Access Collaborative. And so this whole idea of authentication, the
Yes.
beginning, and the general topic of privacy is, there's always some nuances for our colleagues who our children's hospitals. And so someone is asking, due to legal reasons, how does this maintain privacy for patients if someone is calling without authorization? So mom doesn't have custody, calling to find out if anything is scheduled.
Yeah, so in the kind of context of like proxies and like proxy type of like situations, we rely on kind of a lot of those rules that exist inside the EMR. So when we go to look up, you know, even if I was, you know, dad, presented myself, identified myself, great, got access to my data, lovely. When I say, and I have a question about my son or my daughter, we still go back to the EMR and ask, do I have access to this patient record with the identifiers provided? And if the EMR authorizes it, lovely. If it doesn't, then we say, like, we can't help you with that. And that's kind of, we're relying on the EMR's proxy, Epic and Cerner's proxy capabilities to make sure we stay within the boundary box of what's allowable.
Thank you so much. I appreciate it. And speaking of nuances, someone else is asking about, can AI change to a different pharmacy if the patient requests a different one than it was previously filled, which is a big issue because of insurance changes, et cetera.
Yeah, it's one of the areas we're working on today. And so there's right now kind of the simpler build we're doing is just re-auth the existing script. Now, one of the areas that we've found actually good use case for this, it's sort of sometimes actually it's easier to do things on like a mobile, through MyChart Web or whatever it is. So some of those use cases, and we're still exploring these in fairness, is send the patient to MyChart at that point, or send them to the Oracle portal. Say like, great, like we're happy to help you with that. If you need to make any changes, I'm going to text you a link so you can see it on a map or whatever it might be. So we're still exploring that, but out of the box, the initial builds are about the kind of the exact pharmacy that you're at right now.
Thank you so much. And this is a really great question. Can you be selective with the types of appointments that are included? Are only certain visit types or appointments included? Can you include joint appointments or multi-D clinics? And I'll just expand that, Michelle. I know you and I have talked about this where, do we reschedule an appointment or do we pull up an appointment that requires a prior authorization that we haven't received? So now we're getting into like, we know super duper patient access. So yeah, just kind of, just talk about integrating some of those nuances, if you will.
So for me, I do not have surgery scheduling within my access center. So this would not be a place that they would call for anything that is, when I say procedure related, I'm talking about endoscopy, any kind of surgical procedure, anything like that. There's an entire surgery schedule team that they're told to call and manage through that. So that eliminates that whole, we're just going to cancel somebody off the schedule at the last minute. This is primarily right now, unless something has changed, and I haven't been on all the calls recently, but it's primarily just appointment scheduling. People that are directed to our call center to cancel or change an appointment.
Yeah, and also, to build on top of that, in the rule sets that we make available, the business logic, if you will, if you don't allow these, we can set visit types to not be cancelable by, an AI agent, require to speak to a human. And great use cases for this are not only the ones you listed, Michelle, the ones you mentioned, Elizabeth, sorry, but also things like, infusions and like other things like that have to happen on very specific intervals. We don't really want to allow patients to reschedule that without having a really good understanding of why and what the medical outcome of that might be.
Yeah, it's a great point. Okay, so, and this, I just want to piggyback on Michelle's comments before, but as we're talking, like, this is why you can't just have a generic solution that, a bot that you can cancel all appointments, because as access leaders, we know that we're going to have this list of, have you thought about this? Can you do this? Can you do that? Et cetera. So why a partner is so, so important. Well, let's talk about our next question. If the referral is able to be transcribed with the scheduled appointment, be automatically linked to the referral so that any prior authorizations can be initiated.
So if I understand this question correctly, this is probably in that slice that we talked about, the future work, which is the fax work that we're doing. The product name is called Fax Transform. And yes, the goal, like the integration with Epic on that one, is that document comes in, order is created, referral is created. Any appointments that are generated off of the referral are then linked to the original source documentation. So you have clean linkage across the entire document set that's required for that service, if I understand the question correctly.
Okay, thank you. And certainly if anybody does have any nuances, feel free to throw those in the chat. So Michelle, this is for you. From your experience, which job tasks that you've moved to AI and or considering moving to AI would have been the most impactful? And which ones were the easiest to implement?
So everything has been, it was easy to implement the after hours, call cancellation line. But prescription refills and the referral stuff, once we get that completely knocked down, will be just as easy to implement. We're going through the due diligence right now, making sure that, back to Aditya's point, there are certain things we don't want to cancel. There are certain medication, scheduled twos, we're not gonna be able to refill those things. So I will tell you what takes the longest, in my opinion, and it's not long when you consider 3 weeks, it's just the use case. What are we going to do and what are we not going to do? And once you have that delineated, it's super easy.
Yes, great point. All right, so back to Navigator. So once Navigator successfully cancels or reschedules the appointment, and then there may be automated wait list in Epic, we call it FastPass, workflows can fire to get that original slot filled after hours as well. Does that happen? And then does that, of course, further contribute to your return on investment?
Well, I'll let Michelle,
Go
why don't
ahead.
I can add a couple of the workflowy type of stuff afterwards too.
Yeah, so we are able to see the backfill. We're able to see that the fast pass was offered. We're able to see all of that. So we had great pre data, right? So we could say out of these 3 hours, and it's very rudimentary, out of these 3 hours, 182 people canceled, 183 people canceled, whatever it was, 200. And then we would see where the no-show rate was or the late same day cancel. After we implemented this, we've seen the no-show rate obviously drop. We've seen the same day late cancel drop. And then we've also seen that the fast pass is going out more frequent. Like we're sending it out more frequently to backfill those positions or those templates. What I will say, and it's a unique thing to UMS, we all have 8 a.m. appointments on our templates. Our providers do. Nobody wants 8 a.m. So the 8 a.m. slot 9 times out of 10 always goes unfilled, no matter what we try to do. But there is on occasion that we do get a backfill for that. So yes, we are definitely seeing the impact of having it canceled and the backfill.
And just kind of speaking a little bit more to like the technology, the integration, that sort of stuff, and maybe kind of answering a question along the way here, which is how does it work with Epic's Hello World? So the Luma Navigator solution, the Fax Transform solution, which is kind of in UAMS's roadmap, it all sits inside and integrates with the existing Epic native technologies. So when we cancel, it's no different than like, a registrar or an agent right-click cancel inside of Cadence or Appointment Desk, right? All the same workflows kick off underneath that. If they book an appointment through Navigator or they get scheduled through a fax that comes in with Fax Transform, it still gets serviced by the appointment reminders that happen out of Hello World. So we sit kind of in the same ecosystem that Epic provides and just kind of add services on top of it. So you get the benefit of not having to build again for those things. You get the benefit of actually taking everything you did in those other tools and just feeding more pathways to activate them.
Thank you so much. And one more sort of semi-technical question, if you don't mind, Aditya. Someone is asking, how do you ensure the person using AI, in this case, presumably the caller, patient, et cetera, is in fact the patient themselves, or maybe even a person themselves?
I've had this running gag that we're going to solve interop in healthcare, but just having AIs call each other. So we'll see how that actually pans itself out, because I think there's a chance that might end up happening. But short of that joke, we rely, like, there's like, much like your agent who's sitting inside a Cisco UCAS or whatever it might be, or, Five9s or whatever it is, they see the inbound call, the caller ID attached to it. We see that same data. So we start with that fundamental piece of information, which is what is the caller ID? Underneath that, then we ask the patient to identify themselves with first name, last name, date of birth. Those kind of data points, those identifiers, one which is provided by the telephony system, one that's provided by the patient, those identifiers together come together to put it to authorize the access to the data.
Awesome. Thank you so much. Well, it looks like we've got about 4 minutes. So to me, this is a great opportunity to give both of y'all about a minute or two to kind of wrap us up on this journey. Aditya, I'll start with you and then we'll turn it over to Michelle.
Yeah, we're really excited. We've been super blessed by having the opportunity to partner with Michelle and, Holly and the other folks at UAMS. Really incredible thought leaders, very much at the tip of the spear around what can be done to make their team's jobs better, more effective, and ultimately be in the service of their patients. So first and foremost, just incredibly appreciative and grateful for the partnership and their vision on what can be done to make to use AI to make that better. Secondarily, would love for anyone who's interested in taking advantage of these technologies, scan the QR code, dial Navigator, take advantage of the PAC-specific offer that we've put together that's exclusively for PAC members. And we'd love to have a chance to chat with anyone who wants to take it for a spin.
Yeah, and I guess my perspective on everything, and as Aditya said, it's been fantastic to partner with them. I come up with wild things and reach out to them, and I usually get an answer, within a day or two of, yeah, let's flesh this out. I think we can get this done, or yeah, this might be something that you really want to stick within your Epic system for, which is something that I really appreciate because there's a lot of vendors out there that really just want you to purchase their services. And I think one of the benefits of Luma is, and I'll give you my use case. We were having difficulty with imaging and we needed imaging prioritized. And I was like, hey, if we can we use AI to prioritize imaging based on a patient appointment? And we talked it through, and it made more sense to work out some Epic reporting than to use Luma for that functionality, which is a breath of fresh air to see people not try and shove things down your throat. So they've been fantastic partners. I highly recommend that you take avail of the offer, and literally no idea is a small idea. So take it and run with it.
Sounds great. Speaking of taking it and running with it, we really appreciate everyone's time on behalf of the Patient Access Collaborative. Thank you for spending this hour with us. We're really excited to be part of this learning community and all be able to learn together. We will have the recording of this presentation. I did drop in the chat both the YouTube video that Aditya shared, as well as there's a great case study that they put together of UAMS and their team. So we hope you'll spend the last 2 minutes calling our friend at the Navigator, testing it out for yourself. I hope everybody has a great morning or afternoon, regardless of where you come from. My name is Elizabeth Woodcock. Thanks, Aditya and Michelle. Really awesome webinar, and we'll see y'all again soon. Take care.
See y'all.
Thank you. Bye.